Messi, go. Sikit. Go, Messi. Oh, go. Messi, go. Messi, go. So pain. Pain.
Metoprolol as the most effective anti-angina drug. Metoprolol is a cardioselective beta blocker used in hypertension treatment and angina pectoris. Angina pectoris is usually the first clinical sign of underlying myocardial ischemia, which results from an imbalance between oxygen supply and oxygen demand in the heart. How metoprolol has been discovered. Sir James Black made several contributions to pharmacology by demonstrating that new major classes of drugs according to basic knowledge of receptor-driven cell signaling systems to clinical problems. Due to his father's death caused by myocardial infarction, he wanted to inhibit the effect of adrenaline on heart. In angina, the coronary arteries are partially blocked, usually by atherosclerosis, which reduces blood flow to the muscle heart. Although Alpitz has proposed in 1948 that widespread adrenaline effects were mediated through two groups of adrenoreceptor, the idea of developing a selective beta-adrenoreceptor antagonist was still quite radical. After joining ICI Pharmaceuticals in 1958, Sir James used the beta-adrenoreceptor selective agonist isoprenaline as a template. Sir James suggested that blocking the effect of catecholamines would prevent angina by decreasing the workload. The application of some medicinal chemistry by John Stephenson resulted in practolol and prontolol, the first beta blocker. The rationale that Sir James used for the development of beta blockers was that by reducing catecholamine-induced effect of myocardial beta-adrenoreceptor activation, the pain due to angina would be improved. A safer, more potent derivative soon followed, propranolol, which is still considered the prototypical beta-adrenoreceptor antagonist. Metoprolol was first made in 1969.
Moving on to the medicinal chemistry of metoprolol, we are going to discuss about the structure-activity relationship of metoprolol. Firstly, the amine functional group is essential for ionic binding interaction to receptor binding site. The ionic bond is the strongest of all non-covalent interaction, making metoprolol is a hydrophilic drug. Secondly, the branching and extension of methyl substituent are beneficial as it fit hydrophobic pocket. This helps to increase permeability of drug to membrane. And the most important part is the substituent in para position of aromatic ring, as it gives selectivity to beta-1 blocker. Due to the lone pair of oxygen, there is an extra hydrogen bonding interaction taking place with beta-1 receptors, which was not taking place with beta-2 receptors. And what about the carbon there? It is a chiral carbon which has 4 different groups attached to the carbon. Thus, the metoprolol is a racemic mixture consists of enantiomer of metoprolol. Which enantiomers of metoprolol is better? The answer is as metoprolol It is because in 3D structure of metaprolol with lesser side effect, the OH should be at the front, which rotate in an anti-clockwise direction, resulting as metaprolol. The benefit of S-metaprolol is, firstly, it is more selective to beta-1 receptor blocker when compared to R-metoprolol, which is more selective to beta-2 blocker. Thus, it is safer for COPD and diabetic patients with hypertension. In the clinical practice in the management of angina, S-metoprolol administered at half the dose of the racemate shows similar efficacy, safety, and a trend toward a better response rate. The addition of succinate salt in metoprolol gives a standard release of the drug. When the drug is a standard release, it means it releases into the body slowly, and usually doctor will prescribe once daily.
Now, I will explain on how metaprolol binds to the beta-1 receptor. Theoretically, metaprolol is designed to have a perfect fit to the receptor binding site. This feature is different to the agonist, which will have induced fit towards the receptor binding site. Metaprolol has higher binding affinity to the beta-1 receptor compared to its agonist. However, it is unable to produce effects or activate the receptor because it cannot change the receptor's shape. This is the general structure for adrenergic receptor, single protein with 7 transmembrane regions. The binding site for adrenoreceptor involves transmembrane 3, 5, and 6. So this is how it looks like when metaprolol binds to the receptor's binding site. The benzene part of metaprolol will form connection to van der Waals binding region. Meanwhile, the secondary amine will have ionic bonding with the ionic binding region. The 2-methyl group will fit into the hydrophobic pocket. The hydroxyl group on metaprolol structure will have essential hydrogen bonding interaction with the receptor. The last special part right there is the one that causes metaprolol to selectively bind to beta-1 receptor. It is a para-substitution on metaprolol that form extra hydrogen bonding interaction.
Now, let's move to the mechanism of action. Metaprolol is a second-generation competitive cardioselective beta-1 adrenergic receptor. It blocks the epinephrine and norepinephrine from binding to receptor. Thus, there will be no intrinsic sympathomimetic effect. At low dose, metoprolol selectively acts on beta-1 receptor and gives leader effect to beta-2. However, selectivity decreases with higher doses. Metoprolol can relieve angina. The mechanism of action is metoprolol will relax the blood vessel, thus the heart rate and the oxygen demand will decrease. Blood flow will increase, and then the blood pressure and the myocardial oxygen demand will also decrease. Metoprolol is non-directing vasodilator by meaning that it does not act on blood vessels on its own. Metoprolol reduces the production of renin by juxtaglomerular cell. Decrease in plasma renin activity will cause vasodilation. In detail, when there is less renin production, there will be less angiotensinogen converted into angiotensin-1, and then less angiotensin-1 will be converted into angiotensin-2 by angiotensin-converting enzyme. When there is less angiotensin-2, there will be less angiotensin-2 bind to the receptor, thus decrease blood pressure. Now, let's discuss about pharmacokinetics. Metoprolol is moderate lipid soluble. Thus, it can be taken orally or by intravenous injection. The absorption will occur at intestine. For bioavailability, metoprolol will have higher bioavailability when taken with food and also in the presence of cirrhosis of liver. Next, we will discuss about distribution. 1% to 2% of metoprolol will remain in bloodstream, while the others will be distributed. 10% of metoprolol will bind to the serum albumin. Metoprolol can cross the placenta and the blood-brain barrier. It can present in breast milk. Metabolism. Metoprolol metabolized by CYP2DC in the liver. The metabolites are alpha-hydroxy metoprolol, O-desmethyl metoprolol, metoprolol SC, and deaminated metoprolol. For elimination, metoprolol is excreted in the urine. 5% will remain unchanged and 95% will escape as metabolized.
Other than angina pectoris, the clinical indications of metoprolol also for hypertension, acute myocardial infarction, heart failure, migraine headache prophylaxis, and ventricular arrhythmias or tachycardia.
Now, we go into metoprolol adverse effect, and I will further explain to you about this topic. For metoprolol adverse effect, we focus on these 3 points. First point is bradycardia, second point is orthostatic hypotension, and third point is hyperglycemia. Let's go through the first point, which is bradycardia. Bradycardia defines as an abnormal vertical rate of less than 60 beats per minute. Bradycardia also related to AV block. Metoprolol reduces heart rate by antagonizing beta-1 receptor in the heart so that the heart is not able to pump blood normally to supply the body needs. For the second point, orthostatic hypotension defines as a form of low blood pressure that happens when you stand up from sitting or lying down. The beta blocker causes the blood flow to reduce below 90/60, and it further affects human body if rising from sitting position to standing due to the inability of blood to reach brain. And the third point is hyperglycemia. Hyperglycemia defines as the amount of sugar in the blood is elevated beyond normal. Metoprolol impairing the release of insulin from the pancreatic B cell. Insulin moves and stores glucose into cell for energy. Hyperglycemia occurs when low insulin causes glucose build up in the blood instead of going into the cell.
Is metoprolol the most effective anti-angina drug? No, metoprolol is not the most effective anti-angina drug, but it can be used to treat angina. Why? Bisoprolol is more better than metoprolol in treating angina. Both metaprolol and bisoprolol are classified under second-generation beta blocker. Both drugs are lipophilic and selective towards beta-1 receptor. But bisoprolol is more better in binding affinity towards beta-1 blocker and reducing toxicity from the body. Bisoprolol is a direct-acting drug that blocks beta receptors found in the heart, which is beta-1 receptor. The workload of the heart will be decreased, results in reduced oxygen demand. This is how bisoprolol controls the angina. Bisoprolol has higher affinity towards beta-1 receptor than metoprolol. Bisoprolol can be metabolized at both liver and kidney, while metoprolol only can be metabolized in liver. If one of the organ is impaired, bisoprolol still can be metabolized and easily to be eliminated from the body, reducing the level of toxicity, while metoprolol cannot be metabolized if the liver being impaired. Thus, metoprolol is not the most effective anti-angina drug, as bisoprolol is better in treating angina.